chapter of anesthesia, the role of ultrasound and anesthesia. So basically हमारा काम अल्ट्रासाउंड मशीन को रेडियोलॉजिस्ट से नहीं छीनना है ना लेना है down to improve ourselves to make our procedure fine. So why it is necessary and what is the role of ultrasound and anesthesia, we are going to discuss on this topic. Nowadays it is tremendously increasing the use of ultrasound, and it is why, because now it is become the key in the perioperative diagnosis. We, just by having the knowledge of ultrasound, we can give better regional anesthesia and other blocks. We can find the new blocks, new techniques, new plain blocks. Various protocols such as blue protocol and FALLS protocols इनने रिवोल्यूनाइज्ड कर दिया है लंग्स अल्ट्रासाउंड को. ट्रांसथोरिक एंड ट्रांसइसोफेजियल इकोकार्डियोग्राफी, जो कि बहुत ज़्यादा हेल्प करती है डायग्नोस करने के लिए शॉक की स्टेजेस को एंड हीमोडायनेमिक मॉनिटरिंग को. न्यूअर एप्लीकेशन ऑफ अल्ट्रासाउंड सच एज एयरवे अल्ट्रासाउंड, ट्रांसक्रेनियल डॉपलर, ऑप्टिक नर्व सीट डायमीटर, इनके द्वारा भी अल्ट्रासाउंड का जो एप्लीकेशन है वो बढ़ी हुई है. सो लेट्स स्टार्ट द इंट्रोडक्टरी पार्ट ऑफ द अल्ट्रासाउंड. Ultrasound basically is a safe and it gives result rapidly. So constantly improving its software and new technology, giving ultrasound a better premium version. Resolution and enhanced tissue penetration also improve the image qualities. So ultrasound is now expanding, and its application in the anesthesia also expanding. Airway assessment, vascular access, transthoracic and transesophageal echocardiography, they are the such applications which we are using. It is also used in lungs ultrasound and neuromonitoring. What is the role, what is the physics of ultrasound? Sometime this is also have been a question that how ultrasound is working. Human sensitivity of sound wave is between 20 to 20 hertz. We can only listen up to 20 to 20,000 hertz. Whereas medical जो अल्ट्रासाउंड होते हैं they work way above than this frequency. They work on 2 to 15 megahertz. We are at 20 to 20,000 hertz only. It is megahertz, 2 to 15 megahertz, this range. Ultrasound waves are created by piezoelectric crystal housed in a probe, and the effect is known as piezoelectric effect. Whereas an alternate current is applied on the crystal, so it changes the shape and vibrate at particular frequency, and this electrical energy is converted into acoustic energy. So this is easy. The piezoelectric crystals, the electric current apply on these crystals, they vibrate and produce a acoustic yani sound waves. So the electrical energy is converted to these sound waves propagate by longitudinal motion, by compression and expansion into tissues. So they produce some echoes, and that's why echo, sometime we use that 2D echo and all. We gonna find why it is known as 2D echo later on. So the wave, because it is sending some waves, those waves have certain characteristics like wavelength, frequency, amplitude and velocity. We have to study also why. Sometimes we have to increase the brightness, and sometimes we have to penetrate more in the deeper tissue. So in what term, in, because ultrasound is a sound wave, so we have to talk in the term of wave have amplitude, wavelength, frequency and velocity. So now there is a transducer. The time taken for each echo to return back to the transducer is proportional to the distance traveled. The longer the distance, the longer the time to reach to the transducer. So the crystal receive the sound wave, reflect back from the tissue and create a gray scale. Based on the time and the strength of the return of the echoes, it acts like a speaker and a microphone. Like We say something and speaker speaks. So some body have different tissues, air, bones, and sound wave travel differently through different medium. So the image resolution is also different, the depth is also different. We can find all this by the sound waves, that which is fluid, which is bone, which is solid structure. Propagation velocity is determined by acoustic impedance. Fluid or blood, they are less echoic, means they create less echo. Hyper echoic they are, so they appear black on screen because easily things pass on them. They can easily tolerate the waves, but some tissues which are fat and bone create stronger echoes. Like if something is उनसे अगर कुछ टकराएगा, like waves, they will return and they hyper echoic. So bone and solid tissues, fat is also in them, they are hyper echoic, so they appear white on screen. So by this method we get to know that this is a solid structure and this is a transparent kind of media, like fluid or blood liquid structure. Now what is how the frequency of transducer depend on the crystal thickness, thus determining the depth and the resolution of the transducer. कितना resolution की depth और कितना better होगा ये frequency पे depend करता है. Higher the frequency of the probe, there are certain probes also. Some you have seen the linear probe, the curvilinear probe. So the higher the frequency of the probe, like linear probe have the 7 to 13 megahertz. These have lower penetration but good resolution, hence a better and superficial structure. So the linear probe we are using, it is useful for superficial structure. It is higher frequency, resolution is the better, but depth not that much. The curvilinear probe, which is at lower frequency, is curved, it lack resolution, but depth, deeper structure is better visualized with them. Good penetration. So if there is a structure which is far below the surface, we have to use curvilinear probe. A structure which is on the surface, like if you want to visualize just below the skin, you will use flat transducer. But if you want to visualize the deeper structure, like in pregnancy, fetal movements, cardiac movements, and below placenta, so the skin, then placenta, then uterus, then baby, and then pelvic organs, other, then deeper structure. So we use curvilinear probe there. Curved phase arrow probe have 2 to 5 megahertz frequency. Low frequency, good penetration, but less resolution. Linear probe, higher frequency, less penetration, but great resolution. Here is the difference. Now we also have heard about the modes of the imaging. There are B mode or 2D mode. B is for brightness. It is the most common used mode, whereas brightness depend on the intensity of the echo and how it is depend on the location of the corresponding structure in the body. This mode is used to रियल टाइम ऑर्गन्स को एवेल्युएट करने के लिए होते हैं रियल टाइम में. ओके, लाइक we get to know we want to evaluate some certain organ, so we use 2D mode or brightness mode. It give good intensity of the echo. But there is another mode known as the M mode or motion mode. It's display a single line axis of the ultrasound beam over a time and illustrate change in the 2D ultrasound appearance with movement. So it changes with the motion. How? It is motion mode. Like if any structure that is like cardiac valve, it will flap. So M mode is used to valve motion, variability of vena cava, lung sliding, and diaphragmatic movement. So if you want to see the movement in a structure, like there's a lever don't move, we know, but the lungs move and friction is there, like walls move, so we use M mode in them. Okay, Doppler mode detect frequency shift, and by moving structure there is a sound reflection also, like blood flow. This is Doppler effect, or moving tissue by tissue Doppler. Okay, blood flow Doppler and tissue Doppler. The color Doppler is used color to represent the speed and the direction of the blood flow. The color is used to detect the speed and the direction of the flow. The red flow is toward the probe, toward the transduction. You understand? Like in artery, the artery having taking away from the heart blood, but it is, if it is taking blood towards the probe, then it become red, and if it is taking blood away from the probe, then it become blue. This is the Doppler transmission. Doppler basically short pulse it send, and wait for the Doppler signal. Then blood velocity from a small region will give the Doppler wave, Doppler effect. Likewise, and from the bigger area, the blood velocity become different, so we can continuously monitor this Doppler wave. Sometimes Doppler is also used in high velocities, but localization is very poor. If there is high velocity, we cannot localize it so fast from flow signal accurately. Now there are certain ultrasound guided procedure. Ultrasound guided procedure have various approaches compared to anatomical method which were conventionally used uh, to find out the structure. Now ultrasound is replacing them. Okay, there are two approaches for the needle. One is short axis view, which is out of the plane approach, where needle is only seen as an echoic dot on the screen. You cannot visualize the longitudinal needle. You just can find the tip. Then this is known as the out of plane approach. See, if a transducer is getting image of full this, and your probe is penetrating like this, so the point is there. But if you are keeping probe in a way that if needle is penetrating like this on this, so you can watch the whole longitudinal needle. This is known as the in plane approach. So two approach of needle insertion. One is out of plane, where you can find on the tip. In plane, you can find the whole transverse section of the needle. Oh, why it is a long axis view, which is also known as the inline approach, where the entire needle transversing can seen, thus reducing the risk of inadvertent puncture and the other structure. Just looking at the tip, you cannot find that behind how many structure are pierced. But in plane or long axis view, you can visualize a lot of structure, that which structure it is piercing. So it is find better. It is found that long axis view is the better. Now we have some needles which have coatings scoring with multi-phase tips and needle guided design to increase their ultrasound reflectivity. So by using them, we can avoid complications. The wrapping, the coating, the scoring, the multi-phase tips, and the needle guiding, it helps ultrasound to visualize better. Now, ultrasound vascular access. How, like central venous catheter placement, very well known technique, which was earlier used blindly, now replaced by ultrasound. We use ultrasound to find the correct position of the central venous axis, and landmark technique is now replaced by ultrasound. And certain patient like pediatric patient, burn patient, patient with anatomic variation, venous thrombosis, coagulopathies, obesities, patient in shock, where it is very difficult to find anatomical position, ultrasound is now a very good tool for us. to release us from such pain. Ultrasound is helping us. So vessel position, its patency, its anatomical variation, it rapidly detect and avoid procedural complication like bleeding and pneumothorax. American Society of Echocardiography and the Society of Cardiovascular Anesthesiology strongly recommend the use of real-time ultrasound for CVC placement in the internal jugular vein. A linear or hockey stick probe is with high frequency is better and used for better visualization resolution for superficial structure which have 17 to 7 to 13 7 to 13 hertz is used for vascular access. Megahertz 7 to 17 to 13 megahertz linear probe. Now ultrasound for regional anesthesia. Regional anesthesia techniques which are earlier by conventional method, it is difficult to found the nerves and it patient exposure to narcotics increased. The efficacy, accuracy, and the safety of regional anesthesia improved with the ultrasound. Length of stay, delirium incidence, overall patient satisfaction also improved with ultrasound. It improved quality and duration of the block because we can find the nerve sheath very fast. Ultrasound can also show dangerous needles and nerve relationship, direct nerve stimulation, or high injection pressure at the tip needle with an epineurium. There are certain blocks which is enhanced by ultrasound, like brachial, lumbar, sciaticofemoral, thoracic, paravertebral, and other placement, and which were initially considered difficult, like facial plane block, rectus sheath, ilioinguinal transverse abdominal step block that cannot be performed without ultrasound, now commonly performed. For epidural and spinal space, which are encased in the bone, ultrasound will not pass, can be done using acoustic window, such as interspinous space, interlaminar space. Ultrasound also used in the chronic pain modalities, and it is replacing CT scan and fluoroscopy as the procedure, such as nerve root block, slit ganglion block, transfemoral, transforaminal injection for radicular pain, facet joint block, infraarticular joint interactions. Nowadays, airway assessment also done by ultrasound. Application of airway ultrasound have gathered momentum recently. The airway related nerve block along with emergency airway procedure assessment of airway anatomy is also done by the ultrasound. Airway ultrasound is performed by submental and the anterior neck approach, both in sagittal plane and the coronal plane. The submental view is the best obtained by the curvilinear probe, which is giving the frequency of. I already told you that deep structure is visualized by the curvilinear probe. It has less frequency of 2 to 5 megahertz, give better depth but not resolution. For resolution and superficial structure, we use linear probe that is around 17 to 7 to 13 megahertz frequency. Now, high frequency probe is best for anterior neck approach where just we have to visualize the trachea. But for some mental, you have to go deeper and curvilinear probe is used. The string of pulse sign, famously known as string of beds, thyroid cartilage, hypoechoic hump, and cricoid cartilage. This gives string of pulse, string of beds sign. Now, false and true vocal cord can also be seen by transverse plane through thyroid cartilage window. Identify vocal cord abnormalities. If there is any abnormality, we can see the vocal cord sign. Now, between subglottic transverse diameter and outer diameter of endotracheal tube, we can give better tube to any patient. Ultrasound measurement of tracheal width can use to select the double lumen tube size as well. So just Previously, we are using some formulas and presuming that this can be fit for this patient. Now we actually measure the distance of the endotracheal tube, a double lumen tube. So, difficult airway and real-time confirmation of endotracheal tube placement by loss of snowstorm sign or esophageal intubation by double barrel sign. If it is in esophagus, we can see double barrel sign. Okay, and snowstorm sign. It means that we are in the wrong place. Diagnosis of epiglottis can be made by ultrasound. Its thickness and cutoff is 2.4 mm. If it is exceeded more than 2.4 mm, it is swollen up epiglottis. Ultrasound can also help us to localize the cricothyroid membrane. And in case of complete ventilator failure, this become the landmark to perform cricothyroidectomy. Ultrasound also used for the placement of the Ryle's tube and difficult tracheostomies. Ultrasound measure the air column width and the level of the vocal cord represent the amount of air passing around the tube and through the vocal cords. This help us to predict post-extubation stridor and denoting presence of laryngeal edema. Now, as we are proceeding to lung ultrasound is now become a part of critical care, emergency medicine, trauma, and lung pathologies, where we can easily find hypoxia and shock such as pneumothorax, pulmonary edema, pulmonary embolism, consolidation, pneumonia, atelectasis, pleural effusion. They are not gold standard, but yes, they are relative to our information and give real-time information about them. When there is an emergency, we cannot go for the CT, MRI, other investigation. Ultrasound help us to get the real-time image. The pleural line is highly reflective and multiple reverbation artifact. They are equally spaced and go slide to slide. They form the A lines. When they go parallel, they form A line. And these are separated from each other by shadow of the ribs. And this is known as bat wing sign. The parallel lines of the pleura, which is separated by the ribs, this is known as the bat wing sign. A normally ventilated lungs in which parietal and visceral pleura slide over each other, which is seen as shimmering movement called as lung sliding sign. This is the normal sign. Small vertical line moving down from the pleural known as the Z line, which do not reach to the edge of the screen, whereas long vertical lines from the pleura reach to the end of the screen due to the presence of fluid in the interstitial space known as the B lines. If B line is present, then A line will disappear. If there is any fluid, when there is no fluid, it is A line. When there is a fluid, then it is known as the B line. So the when B line came, A line disappear. A line is found in normal patient. B line means that it is absent is off. A line, the normal ventilation, there is a fluid. And on M mode, the motion mode, we have already talked about that when there is any structure which is in the motion, we use M mode at the pleural and give characteristic gray pixelated appearance of the lung sliding, which looks similar to the sand on the beach, like sand move with the water. So it give a sand on the beach, which is known as the seesaw sign, and it is help and exclude the presence of pneumothorax. Loss of lung sliding caused by presence of air underlying structure on M mode is the known as the classical stratosphere sign or a barcode sign will become helpful in finding the pneumothorax. The presence of B line and Z line exclude presence of pneumothorax as these signs rely on the opposition of the two layer of the pleura. If you are finding B, A and Z lines, that means the pleural and the visceral layer are So the presence of B lines and the Z line rule out the pneumothorax. Since loss of lung sliding may be caused by any condition which preventing movement of the pleura, lung ultrasound is better at ruling out the pneumothorax rather than ruling in it. The pneumothorax is best visualized in CT, but X-ray also help in. Ultrasound does not give you the diagnosis of pneumothorax, but it is helping in rule out. If there is a B lines or the Z lines, it is ruling out that there is a pneumothorax because the two layer of the pleura is nearby to each other. Pneumothorax can also be ruled out when the lack of lung sliding is due to absence of ventilation, but there is a characteristic pulse created by transmitted cardiac oscillation. This is seen in T-shaped gray pixelate pattern on M mode. So the finding of T-shaped gray pixelate pattern on the M mode also rule out the pneumothorax. Ultrasound also detect characteristic pattern on the consolidation because due to air trap within the fluid filled lungs, this is called as the shred sign, which is found on the ultrasound. This consolidation may be accompanied by the fusion, which may be seen caudally and posteriorly, also known as posterolateral alveolar and pleural syndrome point, PLAPS. So the consolidation can be seen as posterolateral alveolar or pleural syndrome point, in which fusion is seen in caudally and the posteriorly. Lung ultrasound appearance of B lines, also seen in pulmonary edema, pneumonia, acute respiratory distress syndrome, collectively called as alveolar interstitial syndrome, in which there is a fluid between the two visceral and the pleural pleura, parietal pleura. Now, the pulmonary edema has a characteristic that it is dense, multiple B lines, which are typically distance less than 3 mm. If it is more than 3 mm, there is a large fluid, then it is not edema, it is effusion. So, proctolized approach for examination with ultrasound help us to diagnose various condition, and bedside lung ultrasound emergency. Bedside lung ultrasound emergency. This is known as the blue protocol, and fluid administrating limited by lung sonography. Fluid administration limited by lung sonography is known as the false protocol, which is also an important topic. We will discuss about them later on. Now we are going to discuss about the transthoracic echocardiography. Transthoracic echocardiography, which is performed by many anesthesiologists in perioperative period, basically involve four standardized acoustic views: the cardiopulmonary screening and monitoring, so by which we can evaluate basic hemodynamic variables like preload responsiveness, chamber size, contractility, regional valve motion abnormalities. Transthoracic echocardiography is a vital tool in perioperative evaluation. We can also find rapidly deteriorating patient and rapid assessment of etiology of perioperative shock, and we can also find cardiac tamponade, hypovolemia, left ventricular dysfunction, acute core pulmonale, acute respiratory failure can easily be done by ultrasound. Contractility and the left ventricle function also be assessed by eyeballing of the left ventricle, classified as normal, mild, moderate, and severe. Various protocol is used to find the shock, which is known as some protocols known as the rapid ultrasound in shock, rush, rapid ultrasound in shock, focused assessed transthoracic echocardiography, FAT, focused assessed transthoracic echocardiography. So the T quickly assess the cardiac arrest situation without interruption of advanced cardiac life support. It helps us to evaluate arrest, pulseless electrical activity, diagnose potential treatable cause such as cardiac tamponade, tension pneumothorax, pulmonary embolism. So basically, we can save life within real time. So ultrasound becoming nowadays in perioperative period a very good tool. The study have shown that clinician that are trained in short period of time to determine left ventricular function. So in short time, we can find this intravascular fluid status, detect pericardial effusion and other valvular pathologies of the heart. Now, one or more modality, transesophageal echocardiography, which is superior than the transthoracic echocardiography. It is basically used for non-cardiac surgeries. T actually provide high resolution image, which is difficult to find by transthoracic approach. The T transesophageal echocardiography giving better resolution, higher resolution, and in perioperative transesophageal echocardiography, we can find out the real-time, unexpected, unexplained hemodynamic stability. It in T examination, transesophageal echocardiography, there are 11 views for basic hemodynamic assessment. So there are 11 views which are used for basic hemodynamic assessment. The T views are obtained through esophageal and gastric windows, commonly known as mid-esophageal view and transgastric views. Some views are parasternal short axis, apical four chamber view, subcostal views, parasternal long axis view, and there are how basic thoracic views in which parasternal long axis view, plex parasternal long axis view, where the probe position is left parasternal, probe make marker right shoulder. This is good for left atrium, left ventricle, size and function, and mitral valve function, right ventricular outflow tract size, and left ventricular outflow tract is very good, seen by plex, parasternal long axis. Now, parasternal short axis, the probe is also now placed as left parasternal, but the probe marker is on the left shoulder, one toward right shoulder. So we are giving LA size, LV size, LVOT, RVOT, mitral valve function. By short axis on the right shoulder, probe marker on the right shoulder, we are getting the right ventricle, left ventricle size, function, mitral valve assessment, and RWMA. That is known as right, right valve motion assessment. Now, what about apical 4C, where apically 4 chamber, we put the probe at the apex and we find RA, RV, LA, LV size and the function, and TV and MV, tricuspid wall and mitral wall function, gradient, pericardial pathologies. Apical 5C chamber, apex along with all 4 AC, 4 A4C chambers, we also find LVOT, VTI and cardiac output. Subcostally, we put the probe at the xiphisternum. The all apical 4 chamber is visualized, plus volume assessment in the bubble study also done by placement of this view, which is known as subcostal, and the probe is placed at xiphisternum. So one is left parasternal, one is right parasternal, one at apex. Sorry, both probe placed at the left parasternal, but the probe marker in long axis it is toward the probe marker right shoulder, and in left parasternal short axis it is put at the probe marker at the left shoulder, apex and the xiphisternum. Now as we go down, we already lung, cardiac, airway and the various nerve. There is one more two more things remaining. The one is gastric ultrasound, one is neuroanesthesia ultrasound. So in gastric ultrasound, we can that aspiration of the gastric content leading to the very high mortality and 20% up to incidence. So we real time gastric emptying we can check, delayed gastric emptying we can check any position any foreign body or other thing we can easily visualize in the gastric ultrasound. When the patient is on the right lateral decubitus position, the ultrasound assessed for gastric antrum and also liver anteriorly and the pancreas posteriorly. And enteral cross sectional area, the tidal volume of the gastric fluid we can check. Ultrasound help to quantify the grading of the gastric volume. Normally, baseline gastric secretion is approximately 1.5 ml per kg, 100 to 120 ml in average adult. This is normal baseline gastric secretion. This carries a low risk of pulmonary aspiration. So when gastric antrum is totally empty in the supine and the lateral position, this is known as the grade 0 of for the pulmonary aspiration. But the grade 1, when less than 1.5 ml per kg of volume is present of gastric content at gastric antrum in the supine and the lateral position, it becomes the grade 1. And grade 2, where gastric antrum showing the fluid in both supine and the lateral position more than 1.5 ml per kg, it is it is showing that there is a high chance of aspiration. And we use the curved low frequency transducer curvilinear probe, that is 2 to 5 megahertz, is best for gastric ultrasound. Ultrasound and neuroanesthesia. It is a recently evolving technology that ultrasound has gained popularity in assessing intracranial pressure and cerebral perfusion pressure in the neurology. Transcranial Doppler, transcranial color coded duplex Doppler, which is known as the TCCD, and earlier one known as the transcranial Doppler TCD, and measurement of the optic nerve sheath diameter ONSD. Ultrasound can record blood velocities from intracranial arteries by low frequency pulse Doppler wave 2 to 4 megahertz over acoustic window, such as transorbital, transtemporal, and submandibular, to obtain spectral waveform with peak systolic and diastolic velocities. The cerebral blood flow velocity is shown a correlation between ICP and the measurement of pulsatile index. It is the ratio between systolic and diastolic velocity is not affected by the angle of intonation. Thus, it helps the monitoring of ICP. It also helps us to detect vasospasm and diagnosis when the velocities within the arteries in circulopiles exceed the predetermined lower limit of 50 centimeter per second. 50 centimeter per second. It is the lower limit of the predetermined, indicating high risk of delayed cerebral ischemia. So in circulopiles, the lower limit of 50 centimeter, if it is exceeding, then high risk of delayed cerebral ischemia is there. Other important ultrasound application is measuring ONSD, that is known as optic nerve sheath diameter. Optic nerve sheath is directly connected with the dura and subarachnoid space of the brain because it is distensible. Cerebrospinal fluid pressure variation influence the volume of ONSD, particularly in the retrobulbar compartment. If there is a raised ICP, it can easily transfer to the subarachnoid compartment of the nerve, causing enlargement of the optic nerve sheath, and we can get high ONSD. Nerve sheath diameter will increase. ONSD. ONSD. With higher frequency probe, likely closed eye, we put it. ONSD is measured 3 mm behind the globe. If it is more than 4.8 or to 6 mm, it is the normal cutoff for normal ICP. ONSD 4.8 to 6 mm is the cutoff for normal ICP. If it is more than that, it is showing that there is edema in the and ICP is increased. Optic nerve is hypoechoic structure and extending from the retina posteriorly, so it will seen as the black. Ultrasound can also measure pupillary light reflex, especially in trauma setting, where M mode measurement is used for construction velocity of the PLR. So in the summary, we can say it is improving the quality of care, helping us diagnose, monitor, and optimizing the perioperative patients. It is playing a pivotal role in managing various emergencies, hypoxia, hypotension, dyspnea, and ultrasound will be the future stethoscope for all of us, for all anesthetists. Thank you.